For those of you who don't know me, my name is Esther Chernak. I'm a faculty member in the Department of Environmental and Occupational Health here at Drexel School of Public Health. And when I'm not here at Drexel, I also work as a physician in the Philadelphia Department of Public Health, where I have the honor and privilege to work with Dr. Helena Kwakwa, who is today's Grand Round speaker. Dr. Kwakwa is a leading HIV expert in this country. She has a specialty in HIV issues related to women's health, and she's also a native of Ghana and, of course, is interested in HIV in the developing world and in HIV in the U.S. immigrant population. She is a graduate of Bryn Mawr College and also of the Yale University Schools of Medicine and Public Health. She is really one of the most renowned experts in HIV in this country, and we are really delighted to host her today. You should also know that she has hosted many CBUMP and practicum students. You're going to be inundated now at the health department. And she will today talk to us about the HIV Care Continuum and about this innovative health system navigator program in the Philadelphia Department of Public Health. Please join me in welcoming Dr. Kwakwa.
Thank you, Dr. Chernak, for that very generous introduction. While you were speaking, I was looking behind me to see who you may be talking about. But good afternoon, everybody. And thank you so much for joining us today. I know everybody has busy days, and we appreciate you for joining us. Today's topic is engaging HIV-positive patients in care. And this is our attempt at the health department to address one of the foremost issues in HIV today, engagement in care. It's actually a tale of 3 cities, since there are 2 other cities implementing programs very similar to this, and we'll talk about that in a minute. But today's talk is about our story here in Philadelphia. So I'm Helena Kwakwa. I direct the HIV clinical services at the health department at the Division of Ambulatory Health Services. Now, what I'll do today is really talk about the importance of retention in HIV primary care. And then I'll discuss our program here at the health department on engagement in HIV care, talking about the context and the setting, describing what the project actually is, and going over some of the very interesting preliminary data that we've learned from this project. And I'll close with some key lessons that we've learned in this arc of rationalization, development, implementation, and data analysis. So, to the fundamental question, the question fundamental to this discussion: why is engagement in care so important? And when I talk about engagement in care, I actually linking together linkage to care and staying in or remaining in care, retention in care. And as you see from this slide, there are a couple of studies outlined here. In the first one, Dr. Lozina and colleagues actually found that due to the late initiation of antiretroviral therapy, there were actually 3.9 on average to 8.8 years of life lost. Now, late initiation of therapy can be due to late diagnosis, since testing and diagnosis of HIV is a necessary prerequisite for linkage to HIV care, or late linkage to care for someone who may actually have a timely diagnosis of disease. They also found in the same study that approximately 1 additional year of life was lost due to early discontinuation of antiretroviral therapy. Now, that usually happens in the setting of disengagement from care. In a separate study done in Texas, they actually looked in a setting where there were no financial barriers to care. And they compared different groups of people by how many quarters in the first year of care people had medical visits. So when somebody was diagnosed and linked to care, throughout the first year of care, they didn't look at the number of visits, they looked at least 1 visit per quarter. And what they found that compared to those who had visits in each of the 4 quarters of that first year, those who had visits in only 3 of the quarters. So these were not people who were disengaged from care or who were lost to care. They were actually in care, but had visits in only 3 of the 4 quarters of the year. And they found that they had a 42% increase in risk of death. Those who had visits in 2 quarters of that year had a 67% increase. And those who had visits in a visit in only 1 quarter of the year had a 95% increase in risk of death. So from this study, there appears to be something about regular medical visits that seems to have an impact in life expectancy among the HIV positive. Dr. Lucina, who conducted the first study, actually articulated this by stating that her study underscored the importance of developing interventions focused on better linkage to care and retention in care, and that this was especially important for racial and ethnic minority groups. This is the HIV Continuum of Care, as presented by the Centers for Disease Control. These are 2009 data. And what they do here is by race and ethnicity, actually show participation in each step along the full spectrum of the care continuum, from diagnosis to linkage, to retention in care, to prescription of antiretroviral therapy, and to viral suppression, actually measuring the success of therapy, and defined here as a level of HIV virus in the blood of less than 200 copies per milliliter. And you see a couple of patterns jump right out at you. First of all, there is a sequential drop-off from one step to the next along the spectrum, regardless of race, ethnicity, with the lowest participation in the Black population for this national data. Secondly, the greatest point of drop-off you see is from linkage to retention. And so we're not doing such a bad job diagnosing people, getting them in care, but we're not doing a great job keeping them in care. A close second is actually linkage to care. Now, what has happened is that as we've done a better and better job tightening up the two ends of the care continuum spectrum, that has actually thrown into relief the middle of the spectrum where we're not doing such a great job. And so in recent years, there's been a robust effort by the Centers for Disease Control to actually routinize, to make routine HIV testing in healthcare settings. And with this effort, states have come on board actually removing structural barriers that were present to HIV testing by not requiring say a written informed consent or mandatory pre and post-test counseling for everybody who got tested. And now in most healthcare settings around the country, and certainly in Philadelphia, you find that HIV testing is routine. And so that one end of the spectrum has gotten somewhat better. On the other end of the spectrum is treatment. And our treatment regimens have gotten tremendously better over the years. They are much less inconvenient to take. They're never quite convenient to take. They are much better tolerated. They are much safer. They have fewer food requirements, fewer fluid requirements. And the dosing has gotten so much better with co-formulations, with several medications co-formulated in one pill. We now have 4 separate regimens that can be taken as one pill once a day for the treatment of HIV. And the efficacy has also gotten better, as you can see in this slide. This slide looks at randomized clinical trials from prior to 1998 on the left-hand side of the slide up to 2010, looking at these published randomized clinical trials and averaging out the efficacy rates the rates of viral suppression on different medications through the different phases of antiretroviral therapy, you see that success rates have gone from about 41% to 2010, where it was 65 to 85%. And this isn't limited to the randomized trials. You speak to people actually in practice, I'm sure Dr. Chernak will concur, and in practice, where we are managing some of the most challenged patients, some of the patients facing the most tremendous barriers to care and to treatment, we are actually seeing those levels of viral suppression. And so the treatments have gotten much more efficacious. And so what you find is that with those treatments, the life expectancy also has increased. And again, this is regardless of race or ethnicity. This shows data from the CDC showing quite a significant jump in life expectancy from about 10 years to about 22 years. And these data are dated for both women and men, where the life expectancy for somebody living with HIV has increased significantly. And so with that improvement at that end of the care continuum, as well as along with the improvements in testing, we're now faced with trying to explain and trying to improve those spaces in between those ends of the spectrum, specifically linkage to care and retention and care. This slide shows data from our own Philadelphia eligible metropolitan area. These are 2010 data gathered by the HIV Planning Council locally. And in that year, 24% of people in the EMA diagnosed with HIV, this does not include those who are not diagnosed with HIV, had no evidence of care at any point in the year. So that 24% doesn't look bad until you remember that it does not include those who may have had care in 1 quarter or 2 quarters or only 3 of the 4 quarters of the year. Were we to add those numbers to that 24%, it would be a greater number. And so we have a problem here and around the country where we're doing everything that we have learned to do as far as diagnosis, as far as treatment, as far as getting people in care, but we're not doing a great job keeping them in care. So this gets me to our project. And throughout this presentation, I have slides of the different health centers. We tend to live in a world of our own. Again, I'm sure Dr. Chernak will concur, and it's a little different from any other world. But we are very proud of the work we do in the health centers, and so I'll give little hints of that as we talk. This is Health Center 3, by the way. This is where Dr. Chernak works. You're all welcome. So we call our project the EHPPIC, or Engaging HIV-Positive Patients in Care project. That is a local name. The formal name, the official name of the project is the HIV Care Collaborative. It's a 3-site collaborative in health departments, in 3 different cities, and is funded privately by the Merck Company Foundation, which is a non-commercial arm of the company. The other 2 sites are Atlanta in Fulton County, Georgia, and Houston in Harris County, Texas. Our own setting here in Philadelphia is the City Health Centers, operated by Ambulatory Health Services, a division of the Public Health Department here. We provide comprehensive care to the residents of Philadelphia, and the City Health Centers are federally qualified health center lookalike facilities located out in the neighborhoods of the city. Each health center has an HIV clinic fully operating 1 to 2 days a week. Most of them operate 2 days a week, and each center offers every day of the week routine HIV testing. Now, these are data from 2013, in all 8 health centers and ambulatory health services, we served about 84,000 patients in 2013. The health centers are really busy, for those of you who may have been to any one of them. In comparison, the HIV program is a relatively small program. Only 1,000, a little more than 1,000 patients in the same year, 2013. We received funding for this project in 2012. Leading up to actual project implementation, we decided to take a quick look at some of our own retention and care numbers. And what we did was we looked at 2 groups of people who were new to care and lost to care shortly after coming in, and people who were existing patients over a longer period who had also been lost to care. This slide looks at those who were new to care in 2012, 46 patients who were lost to care shortly after coming in. And we found that almost 3/4, 73% of them, were actually lost to care after only 1 visit or 2 visits. Talking to them, it appeared as though there was something about that initial introduction to our setting that patients were not quite prepared to handle. So we looked at those who had been in care for a longer period. We looked at those who were lost to care over a period of a few years. These analyses, by the way, were done by Umar Gay, a graduate of the Drexel MPH program. Umar, you here? Okay. And what we found, among 293 patients who had been lost over a period of a few years, we were not able to reach about 100 of them. We were able to reach 177 of them. And for those we reached, we found out why they were lost to care and whether they were in care, engaged in care at that time, what had happened to them. And this slide shows the disposition of those that we did reach, the 177. Now, the good news is that the largest category was of those who were actually not quite lost to care. They were still engaged in care, just at another facility. The not so good news, now those who were incarcerated also were engaged in care in their correction settings. The not so good news is that there were a number of people who were out of care, and we did try to re-engage them and were successful at re-engaging the majority of them. A few we were unable to re-engage. So this was a disposition of the people who were lost to care. But what we did find in talking with these people also, that the number one reason people fell out of care, the number one reason for attrition we found was that people felt overwhelmed by our system in particular. And when you look at it, the health centers are incredibly busy places. We provide a broad range of medical and social service for the residents of Philadelphia, and along with that multiplicity of services necessarily comes some complexity. This look forced us to actually examine that, because that happened in spite of all of these services at the disposal of all of our HIV patients. In spite of all of these, they still felt overwhelmed by the system. And when you look at the services, what you find is that none of these roles really includes navigating the system at the health center. And so, which one is this? Health Center 6. Health Center 6 in Lower North Philadelphia. And so what we did was devise a program that included some assistance with navigating the system. The other thing we learned talking with patients was that it wasn't only the system in the health centers that patients found complex and overwhelming. They found the systems of other facilities to which we referred them complex and overwhelming. And it could be as simple as a pharmacy we may send a patient to, or another care provider. Patients were struggling with that quite a bit. And so the project is really designed to decrease the barriers imposed by the complexity of the healthcare delivery system, not just in the health centers, but really the healthcare delivery system, and also to increase the accessibility of our HIV clinics to providers who served our patients, but also providers who served Philadelphians that may need our services. We are the safety net provider for residents of Philadelphia, and if our services are not available to the residents of the city, we are not able to adequately play that role. And how did we do this? With health system navigators, 4 of them for the 8 health centers. We put together a consortium of partners to implement this project. Of course, AHS played a central role, but we also had the AIDS Activities Coordinating Office, another division of the health department, actually a division that houses my co-principal investigator on this project, Dr. Kathleen Brady. And what they do with us is really house, manage, analyze all of the data from this project. The AIDS activities, the Action AIDS, is a community-based organization and the largest case management provider in Philadelphia. And we brought them on board because they have a great infrastructure for the navigators. We didn't have to reinvent that wheel. And so they hire and perform all the personnel management for the navigators. We brought on board also an external evaluator, and not on this slide, but incredibly important, especially for the early phases of implementation, was our local AIDS Education and Training Center. Imagine implementing a project like this in 8 different locations scattered throughout the entire city, and with several different organizations, each with a different culture, each with maybe a different agenda. We struggled to get everybody on the same page and to get buy-in from all of the different health centers, and the AIDS Education and Training Center was instrumental in that effort. And one way we did that in the beginning was by sending out a newsletter to the health centers. We actually went out to all of the health centers and presented to them about the project. But then we had this newsletter every other month, also updating them on the process of the project. So what was the intervention? Really, navigation was the sort of the centerpiece of the intervention, the health center system and other systems external to the health center. And not just to the navigators were not just to navigate for the patients, but to assist them, and in the process actually teach them how to do this, because this was a time-limited intervention. So they had to teach them how to do this so that when the navigators moved on, the patients were able to comfortably stand on their own 2 feet. And part of that was also linking them to other services that they may need in the longer term after the navigators were gone. Key among these services, case management. So, oh yes, this was actually the first newsletter. So it talked a little bit about retention, gave a calendar of the training programs, and then talked a little bit about the project. And I think I have the second one here also, introducing the navigators. This is after they were hired. This was the first crop of navigators we had. And we had a really nice quote here. I can't remember who found it. I'm sure it wasn't me. But it essentially said, this was for somebody from the New York Magazine, now you have a system where a person is not just in touch with a clinic or a building or a yellow line to follow. We actually don't have yellow lines in the health centers, but anyway, that's the quote. There's a real person, and that does seem to make a difference for patients, having a real person sort of walk them through the process. So the categories of patients that we refer to the health system navigators, any HIV positive patient who is new to the health centers. They may be newly diagnosed, they may be previously diagnosed and new in the health centers, but all of those go to the navigators. Patients who have been lost to care and are re-engaging in care also get referred to the navigators. And then there's this third category, this sort of in-between category of the loosely linked patient, which is essentially those who are neither fully engaged nor lost to care, those who may be sporadically engaged, or those who may be displaying some symptoms of impending loss to care, those are also sent to the navigators. And that's pretty much left to the discretion of the different care teams at the health center. Health Center 4, I think, in West Philadelphia. So what did we find with this project? And let me just talk briefly about the analysis so that you know exactly what we're looking at. This analysis focuses on 77 patients who were navigated between March and September of 2013. The reason we go so far back is because we actually wanted 12-month follow-up data. So we have 913 data. Now, what did we look at? The time that we took to link people into care or to relink them back into care. We looked at retention and care, and you see here the definition of retention and care. I prefer not to go through the definition because I know it takes a couple of minutes to process that, but people who were staying in care essentially. And then we looked at viral suppression closest to the end of the measurement period. We analyzed it in two ways. We compared those who were navigated with those who were not navigated. And we also compared those who were navigated essentially with themselves. For that same group of navigated patients, we looked at their viral suppression and retention and care 12 months before the intervention, and then for that very group at 12 months after the intervention as well. And these are the numbers. Out of 304 people referred, 135 were eligible. The remainder were those who had been incarcerated, moved out of the jurisdiction, have had evidence of care elsewhere. So for the 135 who were eligible, 57% of that number were actually enrolled. Those who were not enrolled essentially declined to participate in this project. Most of them were loosely linked. There were 14% who were newly diagnosed. And this slide and the next one show the demographic comparisons. Now we compared those who were enrolled and received services to those who were referred but not enrolled as one category, and to those who were not referred at all, the remaining population in the health center. There were two significant differences. One was that the enrolled group tended to skew a little bit younger. And the other was that the enrolled group was just a little bit less stably housed than the other two groups. Other than that, there really were no demographic differences between the enrolled group and the other two. Now, how did we do on linkage to care? For the newly diagnosed patients, we actually had 90% of them receiving care within 3 months, 18% within 30 days of enrollment. Now, the 90% at 3 months actually exceeds the national HIV/AIDS strategy target of 85%. For those who were previously diagnosed and were loosely linked or had been lost to care, 85% also received care within 3 months. So that wasn't too bad. Now, what about when we compared those who were navigated with those who were not navigated, looking at their retention and care rates and the viral suppression rates? The retention and care rates were actually quite similar. No significant difference between the two groups. The viral suppression rates for those who were navigated was a little bit lower than it was for those who were not navigated, which is on its face a little disappointing until you remember that the group that was navigated is actually quite a unique group, very different from the group that was not navigated because they did not need navigation, or they were not perceived as needing navigation. This is a group facing barriers that puts them at tremendously higher risk for lack of viral suppression and for lack of retention and care. And so our next step was to look at that specific group that was navigated because they were struggling, comparing 12-month prior to navigation and 12-month after navigation data. And this is what we find. For that group, this was their viral suppression broken into 3-month chunks. The viral suppression before intervention and after intervention. And you see that there was a significant increase. And the increase was even greater when you looked at retention and care from 12 months before intervention to 12 months after intervention. So there was something about the intervention that had longer lasting effects beyond the duration of the intervention. So in summary, those who were navigated were younger, they were less stably housed. Linkage rates were quite high at 85 to 90% for both groups of people, those who were newly diagnosed and those who were not newly diagnosed. The retention and care for the enrollees compared to the non-enrollees was no different. But when you looked at those who received services, their retention and care rates increased significantly from 13% pre-enrollment to 95% a year after enrollment. With viral suppression, the enrollees compared with the non-enrollees were less likely to be virally suppressed, and that was statistically significant. But looking at the enrollees alone from 12 months before to 12 months post-intervention, the rates increased from 33% to 68%. So given that, and this is Health Center 10 in the Northeast on Cotman Avenue, let's look at some of the lessons we learned through this project. But let's start by looking at how we fed into the same project, how we sort of informed the project from the lessons we learned by making some program modifications. The earliest key modification was actually limiting the duration of the intervention. Early on, anecdotally, we had a sense that patients were benefiting from this intervention, but we saw that the navigators sort of tended to hold on to them. They were almost afraid to let them go. And so there was very limited access for sort of the second wave of patients who needed these services and so on. So we limited the duration of the intervention, looking at similar programs around the country, to 90 days. And this increased access for patients on a rolling basis. Recently, the AIDS Activities Coordinating Office has begun a practice of actually taking our lists of lost to care patients and running them through these large surveillance databases to screen this list of lost to care patients and determine a disposition for people who are incarcerated, for people who may have died, for people who may have moved out of the city, or for people who may be in care elsewhere in the city. And this has significantly decreased the workload of the health system navigators. And so we were actually able to decrease our complement of navigators in the health centers to 3 because of this. And what we did with a 4th navigator was fill another need we had identified, which was a need to link people getting diagnosed in the largest STD clinic in the city to the ambulatory healthcare sites. And so we now have one navigator embedded in the city's largest STD clinic, which is quite close to the city's TB clinic as well. And people testing positive at either site have the option of getting linked by a navigator who is actually on site and can actually do a warm handoff of the patient to the teams at the health centers. We started that in August of 2014. And looking at other lessons learned, there were many times when we came to a crossroads and didn't quite know which way to turn. This is something that HIV, in the world of HIV, we haven't done very much of. In the world of oncology and in other areas in medicine, system navigation is not new. But in HIV, comparatively, it is relatively new. And so we had to learn some of these lessons the hard way. And some of them were quite simple lessons. For example, in delineating roles. Of course, we delineated roles when we started, but there were several, even though there was nobody on the traditional team, the pre-navigation team, actually doing navigation, there were several gray areas of potential overlap between what the navigator did and what some other people on the team did, such as case managers and social workers. And so we had to be very clear in refining and reworking the role definition and communicating all of that as we went along in the early days. Defining eligibility also was important, although we started out by defining the eligibility criteria that we just went over. The health centers are incredibly busy places. We serve a large number of patients who face a lot of different challenges, and sometimes there was a tendency to refer people to the navigator just because it wasn't really clear that that person's issue was something that had to be managed by somebody else on the team. And we had to work through all of that and make really clear what the eligibility criteria were with concrete examples. Staff turnover among the navigators was an issue, and this was actually an issue at all 3 sites. And looking through the literature, historically it's been an issue in this kind of a program. And so we had to work with a navigator staff, with Action Aids, who was actually the employer for the navigators, to try and reduce that. And the funder actually was very helpful with that. Merck actually sent out a group of consultants to all of the sites to conduct an analysis and make recommendations on how to minimize staff turnover. But it is something we had to deal with, and we also had to refine our transition processes from one navigator to another. This project has been a large collaborative effort. It's been a successful large collaborative effort, but it wasn't without its bumps and bruises. These are different large organizations, each with a different culture, and we had to learn how to work together and how to understand and respect each other's culture as well. And the last one was also a hard lesson for us to learn. This doesn't work for all patients. We still absolutely have patients who are linked to care or re-engaged in care, stay in care for the 90-day duration of the intervention, and then drop right out again. And we still have patients the navigators work diligently with and are not able to get into care. And so we still have a small cohort of patients that this sort of doesn't work for, and we're still working to try and find other solutions for. So in summary, for patients receiving primary care and support services, at least in our setting, health system navigation has helped to improve retention and viral suppression. And we didn't show this, but also satisfaction with care. Our project does show that it can be implemented in a large public health system. And I kind of see that as sort of the stress test of, can you implement health system navigation, period. And it can be successfully implemented as a collaborative effort. I'd like to thank and acknowledge all the different people from all the different organizations who helped make this work. From the AIDS Activities Coordinating Office, Dr. Brady, who is the co-principal investigator, and from Ambulatory Health Services, Umar and Natasha. From ActionAIDs, of course, the staff who helped make this successful, and from the Health Federation, the group that worked very closely with us and continues to this day, and of course, the Navigators. Thank you.
On one of the slides, you were talking about improvements to the system, and you were looking at databases in order to determine who's re-enterable and who's not, to take that burden off of the navigators. At what point do you draw a line between trying to re-engage patients and deeming them not re-engageable?
Can you try to repeat the question?
Absolutely. The question is, for those who didn't hear it, there was a slide where we talked about, when we talked about program modifications a few slides back, when we talked about running our list of lost to care patients through large surveillance databases to identify who on that list was not re-engageable. And the question is the definition of not re-engageable. Those who we deem not re-engageable are really those who are already in care elsewhere and so don't need re-engagement, and those who are sort of beyond engagement, such as those who have been incarcerated, those who are currently incarcerated, those who have died, and those who have moved outside the jurisdiction. Yes. And so that leaves us with a list of those who have no evidence of care elsewhere and still living in the city of Philadelphia, and those are the ones that we then focus our efforts on.
Other questions?
Is there something distinctive about our patients with HIV or about having an HIV diagnosis that makes it difficult for the patients to navigate the system? Or do you think if we did a similar analysis for, say, patients with diabetes or other chronic diseases, that we would see a similar difficulty in terms of sticking with a long-term regimen of care?
That's the $64,000 question. And for those who may not have heard, is there something specific about the HIV-positive patients in our system that makes it more difficult for them to remain in care and stick with their regimens? Or is it something that may be more generalized within the patients? And this is my opinion, I think that a lot of the barriers to care that a lot of our patients face are really, really heightened for the HIV positive patient. Barriers such as fear of lack of confidentiality, stigma, confrontation of a diagnosis, and each medical visit being a reminder of that. I think that that's particularly heightened for the HIV positive patients, especially for neighborhood health centers. We have had patients come to some of the health centers and see half of their neighbors there, either as staff or as other patients. That is something that is a problem for the HIV positive patient, not necessarily for the patient with hypertension.
You mentioned that you were trying to still figure this out, but in terms of how to reach that population that's lost to care and is still engageable in care, what's your hypothesis for how to do that? Do you have one or any sort of opinion for how to reach that population?
Yes, and that's
Could you repeat the question just briefly?
absolutely. That's another question that we often discuss. And the question, for those who may not have heard it, is for those that we have not been able to engage in care in the long term, even with this intervention, what are some thoughts as to what may work for them? Was that your question? I don't think there's a one-size-fits-all approach. The greatest barriers, and I'm thinking about anecdotal stories now as I'm answering your question, the greatest barrier for each of those patients seems to be a little different. And so the answer for each of them, and fortunately it's a small group, may be a little different for them. For some people, it may be drug rehab. For some people, it may be stable housing. For some people, it may be mental health, engagement in mental health care. For some people, it may be finding a way to just deal with a denial of their diagnosis. So there's a plethora of reasons why there is that recalcitrant group of people.
A question regarding the sustainability, scalability of your intervention. I was wondering if you could comment on the current state of reimbursement for navigation services with the HIV population or even more broadly.
Yes, another ongoing, unending discussion in the health department, and everybody heard that, I assume, as it came from the back. I believe that this is an intervention that is eminently scalable. The issue is sustainability. And this is an approach that is gaining in acceptance in HIV. I will say that that list of services that we have available to our HIV patients, this is a model of care similar to the medical home model that has evolved for HIV, and that is funded on the federal level, on the state level, on the local level for HIV programs. Health system navigation has not been traditionally a part of that. But as we get better again at dealing with the ends of the care continuum, I think there's a growing recognition that we need something like that, and that none of our currently accepted roles really can incorporate that. And so hopefully it will become one that is more standardized and that is supported.
Other questions? I have one question.
Yes.
You may have said this. How does the Philadelphia data differ, or is it similar to the other centers across the country?
Great, and I know you all heard that. I actually haven't seen the similar data from the other centers because they're all implementing it a little bit differently. Fulton County in Georgia is looking more at retention, but they have a different setup where they really don't retain their more advanced patients in care, so they're analyzing it a little bit differently. And Houston is focusing more on linkage, and they haven't started looking at clinical data yet. And so that also is a little different.
We're ahead of the game.
What factors have you identified as being the most important in the first visit that retains patients or doesn't?
Absolutely. The factors we have identified as being the most important for retention in care, we have actually found that a belief on the patient side that the care team is truly invested in their well-being and is truly interested in their input, their participation in their own care seems to be tremendously important. Also, we found, and again, this is through this process, that if that initial contact is sort of broken into bite-sized pieces, it's not so overwhelming. Something as simple as, when you come in every time, this is what you need to do, this is why we need this done, this is what this is for, and so on and so forth, seems to go a long way toward settling them and making them feel a little more comfortable and confident in being able to utilize the system.
I'm wondering with the deaths that you see of the people in the program, whether they are due to immunodeficiency conditions or whether they're the usual chronic diseases like heart disease and hypertension and diabetes, that we see in the children population.
Absolutely. And the question, for those who didn't hear it, is about the causes of death that we do see in the HIV program. And it's a mix of those. We are seeing over time more and more and more causes of death being chronic conditions such as heart disease and diabetes and non-HIV related causes of death. But unfortunately, we still do see those deaths that we absolutely should not see in this era of people dying of infectious causes that are directly HIV related. Those are things that we so know how to manage and so how to prevent, and we shouldn't be seeing them today, and we won't be if people are engaged in care and getting tested in a timely fashion.
How important is it to engage family members of the individuals that are in the program?
Absolutely. Engaging family members in the program, how important is it? And the answer, I would say, is that it's important for those who want to engage their family members. We see many, many patients whose family members don't know their diagnosis. For those, it would be a mistake to engage the family members in the program. But when they have disclosed to their family members, we do work hard to try and bring them in to do some education about the disease and about living with someone who has the disease. Sometimes we have to get very, very basic. What can you or can't you do safely in your home with someone living there who has HIV? There are a lot of misunderstandings about that. But involving the family members of those whose family members are aware of their diagnosis is very important.